right, and last but not least, we're going to hear about updates in medical oncology, and I would like to introduce our final speaker this evening, Dr. Marleen Meyers, who is a clinical associate professor here in the Department of Medicine and the director of the Survivorship program here.
Thank you. Good evening, everybody, and I'm thrilled to be here. I'm thrilled to see all of you here, even though this is, for many of us, a very hectic week. It's great that you're all here. So I don't actually have any overlap, so everything we're going to learn tonight is new, hopefully. So let's just start. So I have no disclosures. So we're going to talk about several topics tonight that include duration of Trastuzumab, which is a drug called Herceptin in low HER2-positive breast cancer, the use of CDK inhibitors in premenopausal women, new approaches for triple-negative breast cancer, Pathologic CR, which stands for complete response as a surrogate, Acupuncture for aromatase inhibitor joint symptoms, and optimal duration of adjuvant endocrine therapy. So don't worry if you don't know what these phrases are. We'll explain I will explain as we go along. So first, some basic concepts that you need for the rest of the talk in terms of types of breast cancer and types of responses. And the first one is HR-positive breast cancer is hormone receptor-positive breast cancer, meaning that the breast cancer responds or is stimulated by estrogen in the body. HER2-positive breast cancer tends to mean a more aggressive kind of breast cancer with a receptor on the surface called the HER2 receptor. Adjuvant therapy means therapy after the tumor is removed. Neoadjuvant means therapy before the tumor is removed. And metastatic therapy is for cancers that have spread. Targeted therapy basically means more selective therapy, so unlike chemotherapy that destroys all rapidly dividing cells, targeted therapy is a little bit more finessed and secretive, and selective, I should say. PCR is pathologic complete response, and we're going to see very importantly the difference between overall survival, meaning how long do you live, versus disease-free survival, meaning how long does the cancer stay away. So as medical oncologists, because we don't radiate and we don't cut, we have to come up with crazy acronyms. So we're going to see a lot of that tonight. So the first trial we're going to talk about was reported called the SOLD trial, which stands for Synergism or Long Duration. And we've known for a long time that Trastuzumab or Herceptin is a very, very effective drug, but we really didn't know how long to give it. And the background of this trial is that the standard duration of Trastuzumab or Herceptin was classically for 12 months, and 12 months of therapy is a long time. And interestingly, this was not developed on any scientific method. It was just sort of done that we gave 12 months of Herceptin. The only trials historically looked at 12 versus 6 months and showed that 12 months was probably better, but not very robust. So we really didn't know what the appropriate time to give was. What the SOLD hypothesis stated was that the administration of Trastuzumab concomitantly with a taxane, and taxane is chemotherapy, for a brief period of time is not inferior. So we're not looking to see whether something is better, we just want to see if giving 3 months of Herceptin versus a year is not worse. And you can see what the initial schema was on the bottom. Basically, the drug that was used, the taxane used, was a drug called docetaxel, and that's what the D is. So women got 3 cycles of that, followed by 3 cycles of FEC chemotherapy. And you can see that the Trastuzumab was given for the 3 cycles of docetaxel. And then what happened was people were randomized 50-50 to getting a full year of Trastuzumab versus the docetaxel Trastuzumab alone, so it was not continued after completion of chemotherapy. The key points are that 1 year was not based in research data. The primary endpoint was non-inferiority, disease-free survival, so we did not look at overall survival. And the disease-free survival in the 12-month arm was 90.5% compared with 88% in the 9-week. So in fact, the 9-week appear to be inferior only for disease-free survival, but because of that, it was not considered a positive study. The secondary endpoints were distant disease-free survival, that was no different, and overall survival, very importantly, was no different. So you can see that there's a very, very minimal impact to a year of Herceptin, which makes us feel comfortable that if someone cannot tolerate a full year, by giving less, while it's not standard of care, is still reasonably acceptable. The cardiac failure was not significantly different, 3 versus 2%, and most people's cardiac function resolved. The dose of taxane may influence the outcome. In this trial, they looked at using docetaxel, which is Taxotere. We tend to use Taxol here and at varying doses, so that may in fact have an impact. So the conclusion is that 12 months were costly and lengthy, but still standard of care. As I mentioned, Trastuzumab is a drug that was one of the sort of great events in medical oncology because it had such a big impact in treatment. And the impact in treatment was shown from an older study that was reported out in 2005 that showed the results of something called the NSABP 31, which basically randomized people that were HER2 positive to getting Herceptin versus chemotherapy alone. And when the testing was done, they realized that close to 10% of the people actually were not truly HER2 positive. So this led to the more recent NSABP B47, which said, okay, if all the people were not truly HER2 positive, but still we got good results, perhaps if we look at people that are instead of 3+, are 1+ or 2+, and instead of FISH being 2 and above, maybe were more equivocal, perhaps Herceptin still played a role in this. So this is the old study, the B31, that looked at AC followed by Taxol chemotherapy with or without Trastuzumab. It was done in HER2 node-positive breast cancer. And as I mentioned, when the testing was validated, close to 10% of people were not truly HER2 positive. In the B47, which is the more recent trial, people could be entered if they had a HER2 score of 1+ or 2+. They could have negative nodes all the way up to 10 and more nodes. We took into account the estrogen and progesterone receptor status. And there were 1 of 2 chemotherapies that were allowed, the AC, Adriamycin cytoxan, followed by weekly Taxol, or Taxotere carboplatin, both very well-known trials. Group 1 was chemo alone, and Group 2 was chemotherapy plus a year of Trastuzumab. And shockingly, we were all surprised by the results. These are, believe it or not, 2 lines from the 2 arms, which are exactly superimposed, showing that in terms of disease-free survival, whether or not you got Herceptin, there was absolutely no difference. In terms of overall survival, absolutely no difference. And this was very, very surprising to most of us. The conclusion was that the primary objective of improving disease-free survival with Trastuzumab in HER2 low invasive cancer was not met. None of the secondary endpoints showed efficacy. There were no trends in efficacy, meaning that there was not a subgroup of people, more lymph nodes, estrogen receptor negative versus estrogen receptor positive. There was no trend towards perhaps we should study one group again. There was no difference in outcome if you were 1+ or 2+. Severe toxicities were infrequent, so there was really no harm done in the study. And very, very importantly, patients in both arms did quite well with 5-year disease-free survivals close to 90%. The benefit of Trastuzumab in central testing of HER2 low patients that were seen before and were shown to be positive is unclear why that happened, and the bottom line is there is no benefit with Trastuzumab unless you have a true HER2 positive breast cancer. So let's move on to a newer class of drug which are called CDK inhibitors or cyclin-dependent kinase. And this is basically a schema of growth of a cancer cell or growth of any cell. And when a cell grows and divides, it goes through several phases. And what the CDK inhibitors do is, in one of the early phases of cell growth, it basically freezes the cell and does not allow it to divide. So again, here's the great acronym, Mona Lisa 7, which is Mammary Oncology Assessment of LEE-011 Efficacy and Safety, and LEE-011 was basically the scientific name for a drug called ribociclib. And this study came about because historically, using CDK inhibitors had been basically used only in postmenopausal women who got aromatase inhibitors. And we in fact did not have good therapy apart from tamoxifen or apart from putting one's ovaries to sleep and using aromatase inhibitors. So this trial was really to look at women who were premenopausal with advanced breast cancer. So why is this so important? The estimates suggest that in 2017, 19% of invasive cancers are in women younger than 49 years old. The last randomized trial looking at these women was in the year 2000. And young women may have a different type of tumor biology. Endocrine therapy with ovarian suppression is the recommended first-line treatment. And the feeling was that adding ribociclib, which is the CDK inhibitor, to letrozole, which is the aromatase inhibitor we know in postmenopausal women, was a very, very powerful thing to do and dramatically increase disease-free survival. So what this trial did was it looked at women who were premenopausal or perimenopausal with advanced breast cancer. They did not receive prior endocrine therapy, and they were randomized to either they could be on tamoxifen or a non-steroidal aromatase inhibitor with gosiralin. Gosiralin is a drug that puts your ovaries to sleep and therefore renders you postmenopausal. And they were randomized to ribociclib versus placebo. And unlike the previous straight line where they overlapped, you can see that progression-free survival was considerably improved in the women who got the ribociclib. So key points: median progression-free survival in the group who got ribociclib was 23.8 months versus 13 months in the placebo arm. And this is very much the same result that we see in postmenopausal women. Neutropenia, or lowering of the blood count, was significant, 68% versus 8%. However, women were mostly asymptomatic. So unlike sometimes with chemotherapy where one has to go to the emergency room or get antibiotics, this rarely happened. We're still awaiting overall survival data, but we do expect that to be robust. And therefore, ribociclib plus tamoxifen or an aromatase inhibitor with gosiralin is a potential option for pre or perimenopausal women with hormone receptor positive, HER2 negative advanced breast cancer. So let's switch gears now to triple negative breast cancer, which basically means we've spoken about estrogen receptor positive breast cancer, we've spoken about HER2 positive breast cancer. Triple negative is a cancer where none of these receptors are available. So you can sort of think of it as a cancer cell that really does not, at least on its surface, have anything that looks to be targetable. And it also is one of the breast cancers that tends to be more lethal, more difficult to treat, and have less robust survival. So the current status is dissecting the biology of triple negative breast cancer is very complex, and there's no standard treatment and no approved targeted therapy to date. Clinically relevant populations have been identified in clinical trials. However, a clear roadmap, what do we do with people with triple negative breast cancer, remains unclear. So PARP inhibitors are a newer class of drug, and basically the PARP stands for poly-ADP ribose polymerase, which is an enzyme that helps to repair DNA. So if you have a malignant cell and the cell has been damaged and this enzyme comes and repairs the cell and makes it healthy again, we don't want to do that. So the PARP inhibitor drugs make that not happen, so that the cell will go on and die. So one of the more recent developments in BRCA-mutated breast cancer is a drug called olaparib, which is used in metastatic BRCA1 and 2 mutated breast cancer. And you can see again from these curves that progression-free survival when using these drugs compared to chemotherapy was significant. So this was a good inroad into triple-negative breast cancer. These are just some of the other PARP inhibitors that are being used. Many of these trials are completed but not fully analyzed, but it is a very robust area of development now. In the olaparib arm, tumors shrank by 60% of patients compared to 29% who received chemo. At 14 months of follow-up, patients who received olaparib had a 42% lower chance of cancer progression compared with chemotherapy. The median time to progression was 7 months compared with 4.2. And also very important, the toxicity was considerably less. The PARP inhibitors tend to have nausea, vomiting, anemia, but far, far less than the toxicity of chemotherapy. So defining the roadmap in triple-negative breast cancer in people who have a germline BRCA mutation, it's very reasonable to consider PARP inhibitors, chemotherapy. For the rest of people who do not have BRCA1 and 2 mutations, and remember that's the overwhelming majority of women who have triple-negative breast cancer, there are several options available. So we're just going to talk about a couple more of those options. So one is PD-1 blockade, another targeted therapy. That stands for programmed cell death. And the proof of concept in metastatic breast cancer was the fact that the PD-1 is overexpressed in this cancer, and by blocking it, perhaps we could get the immune cells to work better. Another concept was the use of androgen receptors. We know that in triple-negative breast cancer, which means that there is no estrogen or progesterone receptor, that about 12% of people will express an androgen receptor. And you can target that using a drug that's often used in prostate cancer called enzalutamide. Again, there is no overall survival benefit to date, but it does give us another additional therapy. And again, if we go back to this roadmap, so what are the options? Well, now there start to be more and more options, from chemotherapy to PD-1 inhibitors to various other combinations, but unfortunately it's still a little bit of tried and true where you try one treatment, go to the next treatment, but there is very much a sense of making inroads. So future challenges and directions are that clinical progress is being made, and likely we will see improvement, but there still has not been that dramatic drug like Trastuzumab for HER2-positive breast cancer or hormone blockers for hormone-positive breast cancer. We need to think very critically on how to introduce these drugs and when to introduce them. And we need to resolve regulatory issues, because one very big problem is that as drugs come down the pike, we can't really use the old standards, which are double-blind trials, meaning that a person is randomized to one drug or another. There aren't enough patients and there isn't enough time. So that leads to the next very important talk that was given, and this is about PCR, which is pathologic complete response. And that effectively means that you take someone that has a breast cancer, you treat them first, and then they have surgery, and the goal is you want a complete response, meaning no cancer is seen. And why is this so important is that it may mean, in many instances, that there is a better prognosis. It may advance and speed drug approval, because if we can use PCR as a surrogate to response, meaning that we can give people new drugs before they have surgery and show a dramatic response or an increased PCR, that significantly shortens the time in terms of drug development. We may be able to avoid more aggressive surgery, chemotherapy, radiation, and we may be able to avoid using more therapy afterwards if we get a complete response. It may be able to divide subgroups so we know who best to test and who best not to. And this leads to another great acronym, the I-SPY trial, which is Investigation of Serial Studies to Predict Your Therapeutic Response with Imaging and Molecular Analysis. That just rolls right off the tongue. So, What I-SPY is, it's a sequence of trials, and what this group is trying to do, it's a multi-institutional study, and what the group is trying to do is to try basically different drugs. This last trial was done using pembrolizumab, and see whether or not these are drugs, see whether or not these are drugs that can affect an improved complete response. So we know historically that complete response has a lot of meaning. And if you look at what it does in terms of event-free survival, you can see that people who have a complete response, which is the top red line versus the bottom line, have had complete responses to therapy and do much better. And interestingly, this is an overall trend across all types of tumors. So in triple-negative breast cancer, you can see that the 3-year event-free survival, when they have a complete response, significantly better, as is the distant recurrence-free survival. Same thing, hormone receptor positive, HER2 negative, a little bit less of a difference, but still a difference. And I should just mention that the very, very favorable HER2 positive breast cancers, which are people who have, hormone receptor positive breast cancers, which are people who have very favorable genomic scores, are generally not included in these studies. This is hormone receptor negative, HER2 positive. Again, you can see dramatic difference in people who have a complete response. And again, even in HER2 positive, hormone receptor positive, also an excellent difference. So the key points were that in patients with triple-negative breast cancer, there was an absolute increase in the PCR rate of 40% in people who were given the pembrolizumab. HER2 breast cancer, HER2-negative breast cancer, there was an absolute increase in PCR of 30% in people who got the pembro. Hormone receptor positive, HER2 negative, again, there was an absolute increase in PCR of 21% in the pembro arm. And in summary, we learned that the pathologic complete response is a very strong predictor of event-free survival and distant recurrence-free survival. All chemotherapy in this study was given before pathologic confirmation, so there were some trials in the past where people got chemotherapy, surgery, and more chemo. In these trials, in the I-SPY trials, all the chemotherapy is given first. The PCR is equally predictive across all tumor subsets, so it's good for everybody. And what it does as an endpoint is it enables rapid evaluation of new therapies. So we no longer have to spend a year or two evaluating drugs and then wait for all the people to be enrolled and then evaluate the data. This gives us much quicker upfront validation. The future of I-SPY is actually quite dramatic. It lends itself to testing lots of different therapies. We need to then develop minimally invasive techniques to try to identify a PCR before definitive surgery. Maybe someday there will be people that won't even need surgery. It may allow us to de-escalate toxic therapy. So if you have a 2-type of chemotherapy regimen and you give one type and someone has a PCR, do you really need the other type? And that may avoid a lot of toxic chemotherapy. And it also may allow us to reassign people to other therapy if they don't have a PCR. I'll just briefly mention this trial, and it was, I think, a very important one because of the fact that so many women are on aromatase inhibitors and are suffering from joint symptoms, and this was a double-blind sham versus acupuncture study to decrease symptoms related to aromatase inhibitors, and this was reported by Dr. Hirschman. So that's what acupuncture looks like. And the background of the study is, despite the efficacy of aromatase inhibitors, many patients have side effects. Compliance is tied to those side effects, so if you're in pain, you're not going to take the drug. Acupuncture is popular and it's non-pharmacologic. Several previous studies have suggested its benefit, and the overall interpretation of the trials have been uncertain due to short duration and small sample sizes. So this was really a first comprehensive type of trial. And it randomized people to true acupuncture versus sham acupuncture, which basically means using needles but not putting them in the correct meridians and waiting 24 weeks and then getting acupuncture. The true acupuncture was the standard traditional Chinese medicine. Sham, as I mentioned, was shallow needle insertion, and the wait list were people who waited the 24 weeks but then got acupuncture. And basically you can see that in true versus sham acupuncture, there was a very significant difference. In true versus waitlist acupuncture, a significant difference, and in sham versus waitlist, no significant difference. After 6 weeks, patients getting true acupuncture reported lower pain scores. The mean worst pain was lower than both the sham and the waitlist arm. The proportion of patients who had a large reduction in pain score was significantly greater in the true acupuncture arm. So there were a lot of interesting conclusions that they had shown that with multiple ways of assessing pain, that acupuncture was beneficial. The toxicity was minimal and basically limited to grade 1 bruising. However, and it also supplies a non-pharmacologic option to people who have joint symptoms. Non-opioid options for pain control are a public health policy, and sometimes the pain can be quite severe. However, the cost of the 12 weeks was about $1,250, and that turns out to be a big issue. And the commentary on this trial was that the benefit of acupuncture was real but moderate. It may be that people get worse before they actually get help, so part of the advantage that we're seeing is just a natural decrease in the symptoms. But this quote of $1,250 for 12 weeks is prohibitive for most people, or for many people. So the questions we still don't know is how long will the benefit last? Will some people benefit from retreatment? And are there sufficient practitioners out there? Just because you recommend acupuncture, if you don't have enough staff to give it, that's a big issue. So both the supply of practitioners and the cost may in fact be prohibitive, even if this is a reasonable thing to do. Are we okay time-wise? Okay, so I'll go through this remainder. This is the last really important talk. And this is searching for the optimal duration of adjuvant endocrine therapy. We've all of us involved in the breast cancer field have heard multiple things, and the key phrase that we hear over and over again, or that our patients hear, 5 versus 10. Is 5 okay? Is 10 too much? Is 10 too much? Is 5 too much? Is 5 okay? 7, what about 7? What about 5 of this and 2 of that? So it's a big, murky kind of thing. Again, breast cancer is extremely common. I'll skip this. We all know how common it is and how important endocrine therapy is. The majority of people who have breast cancer have estrogen receptor positive breast cancer, so this is a very important issue. In general, for postmenopausal women, we recommend aromatase inhibitors for 5 to 10 years. You can have combinations starting with tamoxifen first, followed by an aromatase inhibitor. Tamoxifen is appropriate for some women, and again, a total of 5 to 10 years. And in premenopausal women, the only drug available is tamoxifen, unless we do ovarian suppression, at which time you can use tamoxifen or an aromatase inhibitor. So what's the difference? And I think the real key about all of these studies is, while there may be a difference, the difference is repeatedly extremely small. So this is the 10 versus 5 year study, and you can see that the difference, it is clinically apparent and it is statistically significant, but it's a 3% difference. If we look at the Atlas trial, which is a trial that looked at 10 versus 5 years, basically the only thing different was the risk of endometrial cancer was higher in the 10-year group, but it did not impact overall survival. Adjuvant aromatase inhibitors in postmenopausal women is superior to tamoxifen, again by just a few percentage points. Extended aromatase inhibitors beyond 5 years, there are several trials that looked at that, and again, this is where the very important disease-free survival versus overall survival is really important. While one of the studies had a disease-free survival benefit, none of them had an overall survival benefit. So when you think about being on 10 years versus 5 years, and you have joint pain and your bone density is going down and there's no overall survival, I think we need to really think this through before recommending 10 years. Also, very importantly, if you don't take the drug, it can't work. And if you look at adherence, you can see that in the best situation, adherence in one study at least was 85 to 90%. But as a general rule, we tend to see adherence to these drugs of about 60%. So, in summary, continuing tamoxifen beyond 5 years provides a very modest disease-free survival. Continuing an aromatase inhibitor beyond 5 years provides minimal disease-free survival benefit. We have to consider individually the risk of recurrence, the risk of the drug, the person's baseline status, and whether or not it really makes sense to go an additional 5 years of the cost of medication, taking medication, and the side effects if we're really making this advantageous. Perhaps we should be looking into more sensitive things like the features of the individual cancer. We've started using genomic features to try to give us a better idea of which cancers may be more aggressive. One last thing I'll mention is the PALACE study, which is using a drug currently in the adjuvant setting, and it's a trial using the CDK inhibitor in the adjuvant setting because we know it works so well in the metastatic setting. So if that's the case, and if it does in fact work very well, this may put an end, at least for some people, to the whole discussion about 10 years versus 5 years, but it's going to be quite a while before we have this information. And the last thing I'll just mention is, we can skip through this, last thing I'll just mention is one very important study that we're starting to hear a little bit about, and that has to do with body weight and side effects and recurrence of breast cancer. And Dr. Schnabel and Dr. Gerber both mentioned about the side effects in terms of body mass index, and I think this is something that next year and the year after we're going to see more and more of in terms of its importance of toxicity, recurrence, etc. So, thank you.